Good afternoon, everyone. Welcome to the second half of the third annual Cardiac Symposium. And this symposium has been created for you. It's been hosted for you, our participants. And thank you for those who are actually attending their third Cardiac Symposium. We would like to perform a poll where you give your choice in terms of topics. This helps to guide the topics that we bring forth in the symposium. So the first poll is here. I would want you to vote in terms of your topic of choice. Thank you for your responses. I see quite a bit of interest in cardiac complications of COVID-19. Complications of myocardial infarction, congenital heart disease. We'll have that topic later this afternoon. Thank you so much. All right, so we'll be now moving into our Ask the Experts segment. The physicians or consultants who will be a part of this are Dr. Gaydon Osborne, who we would have met already, Dr. Ian Thomas, also presented the last talk in the first half of the sessions. And so we'll invite now Dr. Victor Elliott. Right, so Dr. Victor Elliott is an interventional cardiologist who works at the University Hospital of the West Indies. He's also one of the managers of the PICJ Partners Interventional Center of Jamaica. He's the founder and managing director. He importantly was my mentor during my internal medicine training. We were all assigned to consultants. And he has done a lot to pave my path towards being a cardiologist at this time. So he did speak last year, so some of you would have met him already. So I welcome Dr. Victor Elliott to the panel. Dr. Eric Winter, he is from Antigua, but now lives in Quebec, Canada. He's a consultant cardiologist. He's the director of the Exercise Stress Lab at the Verdun General Hospital in Quebec. And he was also the director of the coronary care unit at the same institution from 1995 to 2010. So now he performs consultant cardiologist duties at the same hospital. So we welcome also Dr. Elric Winter to the panel. So please raise your hands if you have any questions to pose to the panel. And I'll ask them to all unmute their mics and go on to video. Is Dr. Victor Elliott with us? All right, so I'll start with the professionals who are with us, or consultants. I'll start the ball rolling. Dr. Osborne, in terms of generalized seizures, what is the first line of treatment you would recommend, and also for complex partial seizures?
So for generalized seizures, you need a broad spectrum anti-seizure medication. Of the lot, we have valproic acid, we have levetiracetam, and we have topiramate. When choosing a seizure medication, you have to also consider comorbidities. You have to consider the type of epilepsy. If it's a childhood epilepsy syndrome, such as childhood absence seizures, your drug of choice is going to be ethosuximide. If you're dealing with a generalized epilepsy, such as JME, you want to now consider whether or not the patient is male or female. If a female patient, that prefer to do levetiracetam, because as we know, valproic acid is particularly teratogenic, but if it's a boy, you can certainly start valproic acid. If those are not available, or if side effects are intolerable, lamotrigine is also a good option to start. And then you mentioned partial seizures, complex partial seizures.
Yes, complex partial seizures also.
So lamotrigine is also a good choice. As a matter of fact, there were recently two studies, the SANAD trials, which in a sense gave Keppra a bit of a bashing. So I know Keppra is foolproof, very little side effects, doesn't affect the kidney, doesn't affect the liver. And we tend to just start it, at a low dose and, augment it accordingly. But these new studies have shown that Keppra is neither clinically effective or as cost effective as valproic acid for generalized seizures or as lamotrigine for partial seizures.
Thank you so much. Thanks. No, I don't see any hands raised at the moment. If you would prefer to share your questions in the chat, that is also an option.
My camera.
And Dr. Thomas, the ACE and the ARBs, can you shed some guidance in patients with chronic kidney disease or those who have even gotten to the point of being on dialysis?
In terms of their use in chronic kidney disease?
Yes.
Right. So the ACEs and ARBs are really foundation drugs, particularly in patients with heavy proteinuria. They have both hemodynamic benefits as well as other non-hemodynamic benefits to retard progression of the chronic kidney disease. As a result, we try to initiate the ACEs and ARBs if patients have stable disease. Again, if you have high potassium levels, that's not the right time to start the ACE or the ARB. If the patients have known allergies, especially angioedema, certainly ACEs you would try to avoid. But otherwise, those are great drugs, both for lowering the blood pressure, but also for slowing progression. The earlier you start, in general, you'd have, better outcomes. Once you reach late in the game, you might need to back off, or certainly we tend to back off just to buy a little bit more time before persons need to initiate dialysis. Some may argue that this might not be the appropriate thing to do, but our setting is a little unique. We don't have lots of dialysis capabilities to initiate whomever we would love to, at least at the time that we want to. So the ACEs and ARBs, yes, we know they reduce the glomerular filtration rate by reducing the intraglomerular pressure, but long term, they slow progression again, especially in proteinuria kidney disease. In the dialysis population, it may not be as beneficial as, say, the beta blockers, but they still certainly are a good option. One could argue whether they might be second line or third line drugs, but of course, you'd consider potassium control in that population, although, with regular dialysis, and hopefully the patient remains on appropriate diet, we would get, we shouldn't have major issues with hyperkalemia.
Thank you. Thanks. Any questions from our participants? Don't be shy, please. All right, Dr. Elliott. And welcome, Dr. Winter. I did already introduce you. So just to repeat, Dr. Victor Elliott is a consultant cardiologist or interventional cardiologist at the University Hospital of the West Indies. He also is the managing director and founder of the PICJ private medical facility. And importantly, my supervisor while I was in my internal medicine training. So I've learned a lot from him, a vibrant speaker, and he did assisting me along my path to cardiology. So I'm here home now, able to offer these services. And Dr. Winter from Antigua, was with us, our main speaker at our first cardiac symposium, but now living in Quebec, Canada. Welcome, Dr. Winter. And he works at the Verdun General Hospital as a consultant cardiologist. So he has worked in various capacities at this institution. And so we say welcome to you today.
Thank you. Thank you.
Yes, thank you. So a complete panel is here. So I hope all participants would ask a few questions. But for Dr. Elliott, a patient has atrial fibrillation and he's on Xarelto, 20 milligrams. He unfortunately had a ST elevation myocardial infarction and required the placement of 2 drug-eluting stents. So now on clopidogrel, aspirin 81, and the Xarelto. How long would we continue the triple therapy? What is your guidance in terms of the long-term management of this patient?
Okay, that is a very good question. It has been an area of different studies as we have looked on the whole aspect of patients with triple therapy. And there are different guidelines. The Europeans have actually issued some guidelines to help to direct this. What we do know at this point in time, if we're doing triple therapy, the use of clopidogrel is right now the preferred other antiplatelet as opposed to prasugrel or ticagrelor, because it's the one that we have the most studies on, even though there are studies being done with ticagrelor at this point in time. One of the things you have to look on is the patient's bleeding risk. So something like the Hasbled score or some other scoring scenario that will also help you to kind of determine how long you're going to do this. Currently, for most patients, if their bleeding risk is low, we can maintain the triple therapy for say up to 6 months, and then we may end up stopping the aspirin. Interesting enough, not the clopidogrel, the aspirin. They have found that the bleeding risk is actually higher in maintaining the aspirin. If their bleeding risk is kind of moderate, we may go a month of the triple therapy and then stop. But if their bleeding risk is high, you have 2 schools. Some would say just use the clopidogrel with the NOAC, or just a week of the triple therapy and then stop the aspirin. They're actually one school of thought where one set of studies have been looked on to see whether you could just from the very beginning for everybody, just use say clopidogrel plus the NOAC. What the studies kind of indicated that the triple therapy offered the best protection, even better than dual therapy. But of course, the bleeding risk is higher. I've had patients who have kept on triple therapy up to a year. But again, these are low bleeding risk patients, younger patients, and they have done well. Fortunately, I personally haven't had anybody with any major bleeding issues. But my high bleeding risk patients, I have continued for a month and then stopped the aspirin. If for the atrial fib, it means you have to continue them on the NOAC. So it means after a year or whenever, you're just maintaining them on clopidogrel and the NOAC, and that is indefinitely. Even though there are studies also now looking whether you can maintain these patients after a year on just the NOAC. Of all the NOACs that have been studied in the area of coronary artery disease, rivaroxaban is the one that has been shown to be helpful, and it's the one which has the most studies so far. So one can debate if you're going to use a NOAC, especially if you're going to drop to dual therapy, or if you think you are forced to move on to monotherapy, then if rivaroxaban is not the better NOAC to use. I would also say, though, that if a patient is at a high bleeding risk, and with atrial fib and the NOAC, then you may have to consider that patient getting what we call a Watchman device, which can reduce the risk of having a stroke, close off the appendage, and you can then take them off the NOAC after a few weeks once the device is in. So that is also an option for the patient.
Thank you, Dr. Elliott. So I hope that's a bit clearer. We do see it happening quite. We have to make those decisions. We unfortunately don't have a cath lab here, but hopefully that's on the horizon pretty soon. But patients do travel out and we have to manage them when they return home. So we need to know how long on the antiplatelets along with the NOAC. All right.
If I may, just a question for Dr. Elliott. I think I've come across some recent reports that indicate that perhaps apixaban may have a low bleeding risk compared to rivaroxaban. Is that something that you have looked at? Is there anything to that? And what are your thoughts?
In general, the belief is that yes, apixaban has the lowest bleeding risk of all the NOACs. Of course, there are no studies head-to-head comparison of all the NOACs for us to know definitively, but it is the general belief among the fraternity that it is the safest where that is concerned. But it's a feeling, it's an opinion, it's kind of retrospectively looking on the studies and the number of patients who have had bleeding episodes, but we have never done a head-to-head. Again, the issue is, though, we don't have any studies really looking on apixaban with coronary artery disease, but we have that for rivaroxaban. So there, I say you have a lot of different things that make you think and come up with opinions, but we really don't have the studies to justify. So all of this is really kind of based in terms of which NOAC to use. It's kind of based on best guess, so to speak. But yes, I do know some physicians who definitely prefer to use that because, as I said, the general belief is the bleeding risk is lower.
May I, Dr. Winter, Montreal?
Sure.
Just a little comment. I think primarily apixaban versus rivaroxaban is, if you have a GI bleed, I think it's preferably that you use apixaban. I think that's what most people would do. Not necessarily bleeding in general, but if you have a GI bleed, especially a bleeding from the stomach.
And that is true. I remember when the Bigatran came out, there was a big concern with the Bigatran and the stomach bleeding. And yes, there are some studies which indicate, again, rivaroxaban has showed some perhaps increased stomach bleeding. But again, you see, all of this is taken off from different studies and just looking on their statistics, but we haven't had a head-to-head. But again, you realize apixaban somehow is being thought of as the safest of the three. And so you're going to see a lot of cardiologists and other physicians using it with that expectation.
You're absolutely right. I agree with what you're saying.
Thank you. And we do have a question in the chat, and this is directed to all of the panelists. What priority take-home points do you want to share with the public health doctors? Just to emphasize in light of your knowledge and the COVID-19 pandemic. So a few take-home points from each of you based on your specialty for the public health doctors. So we'll start with Dr. Ian Thomas.
Okay, so I think two things come to mind. One, there's this, persistent concern about the safety of vaccination in persons, COVID vaccinations in persons that have kidney disease or, any other comorbidity. Although I think, to the healthcare providers, it's fairly clear that the biggest benefit or the greatest benefit is to be had in persons that are highest risk. Somehow that message seems not to have, filtered out to the community. It's still, the feeling is still that it may be the most dangerous in that population. So I think one is to still encourage persons that, even though they're clearly not a panacea for the COVID pandemic, we still have to, continue the other protective activities or behavior modification to reduce infection. I think they still have a tremendous role in protecting persons from getting severely ill. That's something that we've seen time and time again. So that's one. The other concern that I've seen, and again, it's not really so much for the public health personnel, but there's been a fair, understandably, I would say, persons trying to stay away from, as they call them in Antigua, doctor shops, to try to reduce the risk of acquiring or being infected with COVID. And so some persons have not gone for follow-up in, a year, 2 years, 3 years. Or in the case of those persons that have had, serious financial challenges and are not able to access private care, they too have not been able to have regular follow-ups, because with the surges, clinics at the hospital had to be, I don't know, were closed. Let's put it that way. So we often have persons that have not been able to access care or have not accessed care for an extended period, and then once they do appear, they're really behind the 8 ball, and we're preparing to put them on dialysis. So I think that has been an eye opener, that even though the elephant in the room is COVID, we still kind of have to not forget the basics, the fundamentals of caring for patients with the other non-communicable diseases.
Thank you, Dr. Thomas. And Dr. Elric Winter, your comments?
Well, as far as COVID is concerned, I am very, very pro-vaccination. There's no maybe about it. I don't know what the situation is in the Caribbean, but the non-vaxxers, they are creating a problem here in Canada, and I think also in the United States. For instance, when they do get sick and have to go to the hospital, most of them end up in the ICU. So what do you think happens? A lot of cancer patients, cardiac patients cannot have surgery. Many of the cancer patients, by the time there's an opening, many of them have metastasis. And so it creates a big problem, a medical problem, an economical problem. So I'm very pro-vaccine. As far as the cardiac is concerned, patients who get the COVID, there is a risk of getting peri and myocarditis, which can be quite severe. There is a very, very small chance that you could get cardiac disease, i.e. again, pericarditis or myocarditis with the vaccine. But the chances are very, very slim. So I am very, very much in favor of vaccination. There's no maybe about it. And the other problem that exists in general is that you've probably heard of the long COVID. Long COVID is very bad. It's patients who have acquired the COVID disease and then go on to have symptoms for months. And these symptoms are very real. There was a paper just this week talking about it. And it affects many areas, especially these patients have what they call a foggy brain. They cannot think. They're equivalent to patients who have Alzheimer's. So that COVID-19 is bad, very, very bad. So I think the message is that everyone should get vaccinated. I don't think I can emphasize this anymore.
Thank you, Winter. And Dr. Osborne, your comments, please.
Yeah, well, these two wonderful speakers didn't leave me with much to say. I mean, I'm going to endorse exactly what they said. From a neurologic standpoint, the biggest concern with vaccination was getting a clot, this vaccine-induced thrombotic thrombocytopenia. But I haven't seen a single case. I have not seen a single case. Your risk of getting VITT is significantly less compared to getting a clot or any other complication from COVID itself. So I just wanted to again endorse vaccination 100%. Two other things. One thing I've noticed is that, through the pandemic, and Dr. Thomas had mentioned something like this before, patients have been a bit non-compliant with medications. I don't know if it's because of the psychosocial stress or what, but I feel like as physicians, we can play our role and try to encourage patients to, do what they need to do. Another thing from our standpoint, we need to push telemedicine. If patients can't make it to the clinics are closed, we need to try to push telemedicine so we can reach, the population in need.
May I just comment? You're absolutely right, Dr. Osborne. This is what we have been doing here in Canada. I say in Montreal and throughout Canada, telemedicine. We have been doing that since the advent of COVID. We call all the patients on the phone, and you have to talk with them because they're very isolated. And you encourage them not only to take their medications, but also to get vaccinated. It's an issue. And also, I think I've heard that there are people in Antigua saying that so-and-so is good for the COVID. Well, you should challenge them. I think this is an issue that should be wiped out in Antigua, that other medications are good for COVID. That's not true. And I think this is what we have to do as physicians. We have to challenge these non-physicians who are recommending medications that are not approved. And the population should know about this.
Thank you, Dr. Osborne. Thank you, Dr. Winter. I do see another question in the chat, and Dr. Smith, I've taken note of your hand, but I'll go to the chat first. It was posted first. Dr. Thomas, this is directed to you. Can you speak on the use of NSAIDs in persons with cardiovascular risk and CKD? Some brief comments.
Thank you for that reminder, Dr. Brown. It looks like it's more suggestion more than anything else, but thank you. Yes, I mean, it clearly has been recognized and shown that the NSAIDs are, pose a problem in terms of cardiovascular risk, myocardial infarctions, and perhaps one of the most important culprits, I would say, is diclofenac or Voltaren. We use it quite freely, and I get it. I understand. It's a great analgesic, but we do worry about the outcomes, the cardiovascular outcomes, and certainly the kidney side effects. Just by its mechanism of action, it reduces perfusion to the kidney and can induce acute kidney injury. It can cause, nephrotic syndrome. They can cause tubular interstitial disease. So a variety of effects really. Viralgen is not officially, I think that's metamizole, I think is the generic name. It's not officially thought of or classified as an NSAID. I can speak of its certainly kidney effects. It does, based on the mechanism of action, impair prostaglandin production. So we certainly do anticipate that it will also have negative consequences. So you may ask, what are options? The truth is there aren't great options, but what we generally try to do, if there isn't a kidney issue, naproxen is probably the safest of the NSAIDs. It does have, GI complications associated, mainly bleeding. So we would use, a proton pump inhibitor with it, along perhaps omeprazole. Although one could argue that long-term use has its own problem in terms of interstitial nephritis and CKD. But for short-term use, certainly naproxen is something that we would generally favor if there are no kidney issues. There's some papers that suggest that ibuprofen is also a reasonable choice as well. Apart from that class of drugs, paracetamol is generally safe in regular doses. It's not the most potent analgesic, so we'll typically combine it with the opioid type medications like tramadol or something with codeine. So again, they have their own side effects, but if we're trying to protect or preserve kidney function as long as possible, then those would be my preferred choices. So again, kidney disease, all persons, even if you don't know what their actual kidney function is, even if you don't know that they definitely have kidney disease, but just that they're have risk factors. They're older, they have diabetes, they have hypertension. Be very careful and cautious with prescribing NSAIDs.
May I make a comment? I usually do not prescribe them. I try to encourage my patients not to use them. Instead, use Tylenol or Tylenol with codeine. It's the NSAIDs are very much abused, and once patient gets in them, they tend to stay in them for a very long time. So I encourage my patients not to use them. What you have said is really true, but I try to encourage them not to, and instead use Tylenol every 4 hours with plus or minus codeine.
If I may just also comment, the guidelines from the ACC, etc., actually have NSAIDs as your last choice of analgesics in cardiac patients. They do promote the acetaminophen, then the addition with the codeine, then the addition with drugs such as tramadol. Those are the options before coming to the NSAIDs. The truth is, we know for some patients, the NSAIDs are a necessary evil. Some of our arthritis patients will respond to those medications. Some will not respond except to an NSAID. And so we have to accept there will be some patients who have no choice but to take them, but they have to be monitored very closely for renal and cardiac issues. But yes, it's the last line, it's the last choice, the last line of defense, and not the first one. I just said it's abuse. It's easy to just go and get some ibuprofen off the shelf and take 2 down to deal with any pain. But you have to teach the patients, try others first.
I absolutely agree with you.
Thank you. Dr. Smith, your hand was raised earlier. Do you still wish to ask a question?
Yes, good afternoon. I want to say thank you, first and foremost, to all the presenters so far. Excellent presentation, wealth of information. This is for Dr. Osborne, concerning children having tics, not seizures, but tics. What is the management? And if there isn't anything that basically is done apart from if they're having seizures, what type of medication would you give to a child, pediatric stage, having tics? Once it's ruled out that it's not seizures a person is having, but tics.
Okay, so there's actually a seizure medication that can work with tics. It's called topiramate. Some people also use like one of the stimulants, not methylphenidate. This, not remembering the name right now, but topiramate is a very good medication for tics. Some people endorse gabapentin. I'm not a fan of that, but I really like topiramate and have it available. All right. I haven't seen that many tics since I've been here. It's a high population in Albany where I trained, where kids did come in with tics, but haven't really seen much of that here. But topiramate.
Okay, thank you so very much.
Thank you, gentlemen. And thank you for everyone who posted questions. I hope it was a fruitful session. I did learn a lot of little snippets, and we can apply it to our daily practice. So I'm hoping that we're able to continue these sort of sessions just to allow you any management issues you have with your patients, advice and recommendations. So right now we're going to close this segment and move on to a moment where I would like to highlight that team Dr. Osborne mentioned. We can only do so much on our own. And so I would like to highlight my team, starting with my board. Sumita Baluja, she's vice president and also co-founder of the foundation. Valerie Gonzalez Barrero, MM, and Vijay Tiwani. So behind the scenes, over several months, we've been planning the symposium and getting everything in place. And then the assistant to the secretary, Ms. Chantel Saltwell. She's worked many hours, changing slides, helping with the registration and getting everyone set and ready for today's event. Also part of the registration team is Mrs. Melissa Joseph Telemack and Miss Vanessa Wade. Throughout the month, we've had Homer Jacobs. He's the manager of Red Revolution, the wonderful website. All these graphics you're seeing were created by him. So we say special thanks to him. Mr. Kadim Joseph, he is assisting with our interviews, and we call him our media coordinator. He assists us with that. Dr. Siobhan Bell Jarvis has helped us throughout the month in terms of highlighting cardiac disease in children, and also Dr. Claudine Richardson. So special thank you to them. Dr. Rashida Williams, also a co-founder of the foundation. Dr. Osama Diaz, Dr. Gaydon Osborne, who was presented earlier today, Dr. Monica Osborne Stevens, Dr. Tadia Smith, Dr. Serena St. Louis, and Mrs. Trudy Andover, and Mrs. Stacy Nathaniel, Mrs. June Redhead, Miss Candine Roberts, Mrs. Pooja Tawani, who also assists us with our graphics. Special thank you to her, and Mr. Julian Water and Mr. Ashton Williams. Now, Miss Desiree Zachariah, she's a powerhouse in terms of staging our virtual events. So I cannot thank her enough. Great organizer, just gets everything to the T. And so special thanks to Desiree. So this is my team. And if you would like to join us, we are always looking for persons to, when we're able to get out, we'll be able to do more. But with what we're able to do, I say thanks to my team. Our office number is 732-3861. You can follow us on our website and also our Facebook and Instagram pages that are listed below on this graphic. Any reason you may want to join, a family may have heart disease or stroke. We want to do more in terms of support to patients with these conditions. And we could only do that with, one of the ways is with finances. So if you may have contacts in terms of persons who want to assist, to subsidize echoes, testing overseas, angiograms, cardiac surgery. We're looking forward to your support. So thanks again to my awesome team as we continue this work that we have started. I want to also at this point highlight our sponsors, our platinum sponsor, Novartis, this year came on board to assist us. Our community partners, AUA College of Medicine, Cool and Smooth, LSA Entertainment and Virtual Stage. This is our host for the Command Center, so special thanks to him, and Red Revolution Media.